welcome everyone. Welcome to the 6th in our series of webinars for team primary care. And this one relates to scopes of practice and negotiating roles within a primary care team. I'm going to start with an Indigenous land acknowledgement. And if you want to introduce yourself in the chat and where you are today, then please feel free to do so. So today, while we meet virtually, let us begin by acknowledging the ancestral territory of all First Nations, Inuit, and Métis peoples from coast to coast to coast, upon which we meet today. We acknowledge the need to work collectively and individually to recognize the past and continuing effects of colonialism and racism on Indigenous families, communities, and knowledge systems through the Indian Act, residential schools, Indian hospitals, and other systemically discriminating policies. We affirm our responsibility as settlers to improve relationships between nations and actively seek greater understanding of Indigenous peoples and cultures in the communities in which we live, work, and play. Please join us in this acknowledgement and commitment, each in our own way and through Team Primary Care, to move forward towards truth and reconciliation. So we have two groups of presentations this morning, or this afternoon, depending on where you are in the province. And it's noon, so it's afternoon here in Ontario. So the first presentation is entitled Regulating Scopes of Practice in Canada, presented by two wonderful women. The first one is Kate Leslie, and Kate is a registered nurse and lawyer, and an associate professor at the Faculty of Health Disciplines at Athabasca University, as well as an adjunct professor at the School of Health Studies at Western University, and the governance and regulation lead for the Canada Health Workforce Network. Her research focuses on professional regulation, health law and policy, and governance of the health workforce. Sophie Myles is a research assistant at the School of Sociology and Anthropology at the University of Ottawa and the Canadian Health Workforce Network, and a research assistant in the Faculty of Health Disciplines at the Athabasca University. Sophie's research interests include health law policy, professional regulation and education, and primary healthcare workforce. Over to you, Kate and Sophie.
Great, thank you so much, Dale. I'll just share my screen here. Make sure everybody is seeing that okay. If I can get a thumbs up, Sophie.
That's great.
I see it. Awesome. Thanks, Dale. So thank you very much, Dale, and thank you as well to Ivy for inviting us to join you today to discuss how scopes of practice are regulated in Canada. As Dale mentioned, my name is Kate Leslie, and I'll start our presentation today. I'm going to start with an overview about how scopes of practice are defined in Canada, including the legal and regulatory frameworks. I'll briefly touch on some variations in scopes between jurisdictions and some recent expansions in scopes of practice. And then I'll end with a few lessons that we've learned in conducting a global review around the evidence for scope of practice regulation. I'll pass it over to Sophie then, who will talk about working in teams and interprofessional collaboration and some recommendations from various reviews about how scopes might be optimized. So scope of practice basically refers to the activities that health providers are authorized, educated, and competent to perform. In Canada, regulation of health providers falls to provinces and territories. So this is generally delegated by a statute to a regulatory authority. These are often called regulatory colleges, and these regulatory colleges govern specific practitioner groups. So what health providers can do, or their scope, is influenced by many different system variables. Regulatory bodies and the legal and regulation framework is one influence, but others include collaborative practice agreements, delegation, or other supervisory or authorizing mechanisms, certification models, and funding arrangements. Beginning in the 1990s, many Canadian provinces began enacting umbrella legislation, so having one legislative framework that was common for the regulated health professions within a specific jurisdiction. One of the main reasons for these new frameworks was to provide overlapping scopes of practice, and this was meant to enhance workforce flexibility. When we have an umbrella act, you also usually have profession-specific regulations or statutes. These often confer title protection and include some broad, non-exclusive scopes of practice statements. And then there are usually also a number of controlled or restricted acts. So these are very specific and risky things that health providers do. And so they're restricted to certain providers, but often more than one provider group can do each controlled act. So that's where we get the overlapping scopes of practice. When we have these legislative statements, they're often then used by regulators to develop competencies, guidelines, and standards of practice. So together, having the legislative scope of practice statements and then all of these regulatory policies, this sets the outer limits of a profession's scope of practice. This diagram helps illustrate this a little bit. This comes from the College of Registered Nurses of Alberta. So you can see the overall scope of practice at the top here with this is for the whole registered nurse profession in Alberta. It's described in an overarching statement in the umbrella legislation. In Alberta, that's the Health Professions Act. Then we have restricted activities. And then there are the specific regulatory statements where there's standards of practice, guidelines, and other regulatory documents. So there's your outer limits of practice. And then for each individual registered nurse, their actual scope of practice will be determined by the needs of the specific client population, and then limited by the nurse's individual competencies and any relevant employer policies and requirements as well. In Canada, because scope of practice is regulated subnationally by province and territory, we see a lot of variation for scopes for the same type of provider. This is continuing on with our registered nurse example here. This is data from December 2021 from CHWN. So you can see for activities like at the top here, referrals, ordering diagnostics, communicating diagnoses, down at the bottom, prescribing. There are significant differences between jurisdictions for registered nurses. And scopes of practice are undergoing reform. Scopes of practice are not generally considered static. There are lots of different influences that create windows for scope of practice changes. One that we've certainly seen recently would have been the crisis situation of the pandemic, where some provinces used emergency powers to expand scopes of practice for certain providers as part of the COVID-19 response. We also see things like new technology or new knowledge that impacts on professional practice, changing scopes, new roles being developed to meet system needs, upskilling, role shifting, credentialing. These types of things also influence and change scope of practice. As an example, pharmacist scope of practice is most advanced in Alberta. Prescribing for pharmacists started there in 2006. The three I know about, I think there's probably more, but in 2023, we've had Ontario, Newfoundland, and BC expand pharmacist scope of practice as well to include prescribing. So this is sort of a continual reform here. We also see as part of health workforce strategies that scope of practice is often, within the mandate of some of these workforce strategies to expand or to optimize. So Saskatchewan's Health Human Resources Action Plan, it came out in late 2022, but it's spurred some recent changes. I think it was probably about mid-June, so just a few weeks ago, the Saskatchewan government announced that there would be new expanded roles for pharmacists, nurse practitioners, and advanced care paramedics. So finally, just before I pass it over to Sophie, I wanted to talk very briefly about some evidence around regulating scope of practice. Ivy and I were the Canadian arm for a global team that conducted a review for the World Health Organization to help inform WHO's first global guidance on regulating health practitioners. That should be coming out, target is November 2023. The review encompassed many areas, but one area where we found a lot of evidence was around the impact of regulation on scope of practice. And this really emphasized the importance of challenging some of the historical thinking around how to regulate scopes of practice. So we found that mechanisms used by regulators in many countries to regulate scopes of practice can have unintended consequences of constraining local workforce flexibility, stifling innovation for advanced practice roles, and limiting collaborative team-based care. We also found some evidence that when regulation is conversely used to help expand and secure certain evidence-based scopes of practice reform, that healthcare access and quality can be improved. This was true in both high and low and middle income countries. Most of the evidence here was around prescribing and administering restricted drugs and enabling various health workers to be authorized to prescribe and administer these drugs based on demonstrated competencies. And third, evidence suggested that development and implementation of expanded scopes has historically been contested in sort of a type of turf war, and that successful workforce reform may require governments to manage those types of competing interests in a more interventionist manner. So I'm going to turn it now over to Sophie, who will talk about how this all plays out when working in interprofessional teams.
Thanks, Kate. There are several mechanisms which can impact the scopes of practice of differently regulated providers, 3 of which are orders, directives, and delegation. An order is a direction from a regulated health professional with legislative ordering authority, such as an audiologist or optometrist or registered nurse in the extended class, that allows the performance of a procedure by another provider. There are 2 types of orders, direct orders and medical directives. Direct orders are for a specific patient upon assessment by the authorizer that the procedure is warranted. These are usually written, but can be made by phone, electronically transmitted, or verbal. Now, due to the potential for error and accountability issues, verbal orders are usually not recommended in multi-practitioner settings when the authorizer is present and able to write it out. Medical directives are given in advance by those authorized to give orders to enable an implementer to decide to perform ordered procedures under specific conditions without a direct assessment by the authorizer. And these are always written. Delegation occurs when a regulated health professional who is authorized to perform a controlled act procedure under a Health Profession Act confers this authority to a regulated or unregulated provider who is not authorized to perform it. Delegation may occur by an order or by designation. And generally, tasks do not need to be delegated or supervised by a physician, for example, when the task is part of the scope of practice of another team member who will be performing it. Next slide, please. So we stress that the following information does not constitute legal advice, and providers are encouraged to seek legal and/or professional advice to discuss individual situations that may arise. New and evolving models for healthcare delivery have increased the opportunity for collaborative practice. And professional regulators, protective associations, and societies have created documents and joint statements to respond to members who practice collaboratively. Medical legal concerns are frequently cited as a potential barrier to collaborative practice. Commonly expressed concerns include the possibility of increased exposure to liability risk and being held accountable for the negligent acts, including inaction of other health providers. Each collaborative team is different, and providers should evaluate their individual medical legal risks unique to their team. Risk management strategies can minimize potential liability for health providers who practice collaboratively. The Canadian Medical Protective Association recommends the following steps for health providers to help mitigate risks for collaborative practice. Health professionals should clearly understand the scope of practice of team members, document delineation of responsibilities where scopes of practice overlap, clearly specify and understand overall responsibility for healthcare decisions, have effective and efficient team communications with patients and across teams. These communications should also be clearly documented. Each team member has a responsibility to obtain adequate medical liability protection and should confirm this for each team member. Each team member should understand their individual responsibilities and role within the team and act according to the scope of practice and practice standards of their professions. And it's important for teams to establish clear processes for interdisciplinary care, including care coordination, decision-making, and patient management. Next slide, please. Varying perspectives inevitably arise about care coordination and leadership of teams. Prevailing positions include that a single professional ultimately should be responsible for all clinical decisions and actions, or that a team leader is not necessary. As a collection of professionals practicing within their own scope of practice, the team co-provides care and collaboratively shares responsibility for the outcomes.
Yes, Eileen.
and that the health professional permitted by the regulatory authority to independently provide care assumes responsibility and accountability for independently arrived at health decisions. Understanding of accountabilities among regulated professions can provide a foundation upon which to build collaborative practices. While clear established scopes of practice can help mitigate accountability risks within practices comprised of regulated health professionals, this potentially becomes more complicated when incorporating non-regulated professionals onto the team. Implementing appropriate risk management strategies can alleviate concerns associated with differently regulated providers and promote the development of collaborative care teams. Next slide, please. Responding to increasingly constrained resources in Canadian healthcare, the Commission on the Future of Healthcare of Canada, the Standing Senate Committee on Social Affairs, Science and Technology, and Ontario's Ministry of Health of Long-Term Care all suggested that health professional scopes of practice, as defined by legislation and regulation, be reviewed and expanded to increase access to services. Other recommendations made in Ontario by the Drummond Commission include using the full scope of practice of pharmacists, for government to work with professional regulatory colleges to apply a system-wide approach to health profession scopes of practice rather than doing this in isolation with individual professions, and to use funding as a lever to encourage hospitals and other healthcare providers to use the full scope of practice of their staff to optimize human resources capacity in the province. Nearly 10 years ago, a Canadian Academy of Health Sciences expert panel convened to examine collaborative models of care and optimal scopes of practice for healthcare providers. A fundamental problem with health service delivery models, they determined, was the organization of professional scopes of practice and models of care based on political considerations and tradition. Changing legal and regulatory frameworks from siloed to a more collaborative, patient-centric system to better meet population health needs was among their recommended reforms. In its recently released Pathways Forwards report, CAS identified transforming care through optimized scopes of practice within team-based models, supported by appropriate technology and properly aligned incentives as a priority. A recent report of the House of Commons Standing Committee on Health articulated a need for flexible scopes of practice and recommended optimizing primary care professional scope of practice. The report also suggested that jurisdictional variations in scopes of practice between provinces and territories can result in care access inequities. And as scopes of practice have important health workforce implications, altering professional scopes of practice has also been recently discussed in some provinces. Next slide, please. Typically, scope of practice is determined by numerous stakeholders which have different objectives and do not often collaborate to devise or define health profession scopes of practice and associated competencies. Professionals may lack the expertise and training to practice competently outside their legislated scope of practice. While health professionals tend to describe their scope of practice as broadly as possible, and broader scopes of practice may afford more clinical independence, concerns about the breadth and maintenance of professional competencies have been raised by the medical community. For example, individual practitioners may not have sufficient knowledge and skills to perform all aspects of their profession's scope of practice. Gaps may exist between the clinical abilities of health professionals acquired through education and training and the legal authority granted to perform specific tasks. These gaps have health system implications by reducing health resource efficiency and cost effectiveness. Impeding the best usage of the health workforce potentially limits access to services. Creating or changing scopes of practice can inevitably cause tensions within and between professions that are exacerbated by union contracts with healthcare payers. Overlapping scopes of practice among health professions reflect tensions and competing interests for the division of labor within healthcare. Next slide, please. Thank you so much for listening to our presentation, and we look forward to answering any questions you may have.
Thank you so much, Kate and Sophie. Wow, what a whirlwind of information. It's a very important considerations for all of primary care teams. I see that Isabel has a question.
Hi, it's more of a comment. That's amazing. That's where we're at. I think it's much needed. And I'm talking from a profession that doesn't have much controlled acts. So we need to be referred to, but one barrier is others don't seem to know that and have a hard time understanding our scope of practice. So it is in our best interest to do some networking with our colleagues, but my comment is the following. In some areas of care, such as diabetes management, I feel like the coordination of care from different disciplines is better intertwined, and the understanding of the different roles. And that could be because of the certification. You can be a diabetes educator and perform some of the elements of care for diabetes that promotes that continuity of care for the clients. Because there's some overlap. So different health professionals can be certified in diabetes, and I don't have that credential, but what I understand is you need to know a bit more of what overlaps to be able to help if you're delegated. For example, dietitians don't usually do a foot exam, but if the nurse is not available and the client's in and the meeting with the dietitian starts, the dietitian can do the foot exam because there's been that overlap in the scope that is allowed by the system, and a clarity as to what can be done by different health professionals. So is that then a start point to try to do that in more areas? I'm not saying we need more certifications, but it seems that in that area there was more of a dialogue or an history of overlapping scopes of practice. Thank you for your insights.
Thank you. Kate or Sophie, did you want to comment on that? I see IBO's hands up, but did you want to comment?
Just to quickly say, I think that, that's a great example of the, how a team can work in diabetes management. Maybe that's an excellent sort of case study to see how to optimize care if a nurse is not available and there is someone who can do a foot exam. It seems like this is, intuitively this can make sense, and our credentials a way to have a quality assurance mechanism for these various types of skills that would maybe not require a legislative amendment to have a controlled act changed. I wonder if those are ways to do it. I know that in Nova Scotia there's a new, maybe not as new now, but it's a way of changing scopes without legislative amendment when you're part of this regulatory network. So I think that that's another example that I haven't seen a lot of literature examining how well that works in practice, but I'd love to learn a little more too. If anyone has some and wants to share with me, that would be great. I think that that's another example of, from a regulatory perspective, working together to be more agile and nimble in addressing practice changes.
Thank you. I don't think that we're trying to replace nurses by dietitians here. The message is, how can we work together to provide just-in-time quality service? Another area where I think dietitians have worked a lot is malnutrition screening in the communities, etc., where, I think it's much more collaborative, that you don't need to be a dietitian to do nutrition screening and everybody can help out. So these are other good practices already.
Great, thank you, Isabel. I'll go for Ivy, Nathalie, and then Leslie. Ivy.
Thanks so much, Kate and Sophie. This was great, and I'm glad that it was recorded because I think a lot of people need to be actually hearing this. My question for you is, if you could actually help us understand the differences related to scope of practice, competence, and context, okay? Because I think one of the challenges that we have in primary care is unlike cardiology, that is such a narrow focus of what is actually in cardiology. Primary care spans from acute to preventative to urgency care, from babies to death, and there are healthcare professionals that fall within any of those populations. You may have a particular scope, but over time, if you haven't practiced with babies, you probably should not be practicing in babies. And even though it's in your scope, you really shouldn't necessarily be practicing that, even if you are hired within a team to actually do this kind of work. So could you help us a little bit with the differences and where you might recommend some of the opportunities that we could actually help to articulate, particularly in the primary care context? Scope of practice, competence, and the primary care sector.
I'll take a stab at it, but I'll let Sophie also chime in. Yeah, I think for, how I sort of think of it, and I would happily be corrected by others who would know more, but, I think of context and competence as those other terms you mentioned as, within that upside down triangle, if we're thinking of scopes of practice as this large, that there is this outer limits of scopes of practice, and then that would be potentially constrained by the context and specific context, and maybe fluid within that context. So when I hear somebody sometimes mentioning, full scope or different things, I think that is very context specific. So I think understanding the context there, and then their individual competencies, which, as you mentioned, training at initial registration is going to be, very different from somebody's competence who might be, gain competence in certain areas and in others have not practiced in that specific area. In terms of primary care, I'll pass that over to Sophie in case Sophie has an example and wants to chime in there on how this could apply in primary care and what we might need to make this clearer.
Scope of practice is a really complex construct. So scope of practice is not necessarily aligned with one certification, and that can be very context specific. It could also be constrained or influenced by the actual institution in which one's work. So a provider may be required to acquire additional competencies to have certain privileges in a particular environment. I mean, that's why the Public Hospitals Act and the Healing Arts Radiation Act in Ontario had to be amended, because nurse practitioners were able to order certain tests in some actual physical buildings or institutions, and not others. Some other things that might happen in certainly primary care collaborative practices, and that's where those risk mitigation strategies of first of all making clear of first of all, what can everybody do, and then what is everybody going to do in the team. And it may be an open conversation within a team context of saying, well, who can do well baby visits and handle women care, and if more than one person puts up their hand, then there can be that negotiation of who is going to do what, and then a team can go from there in terms of identifying what service vacancies exist and how to appropriately fill them, whether that can be done within the current team composition, or whether an individual or another practitioner needs to be added. And of course, that knowledge, I've just been following along in the chat, certainly that knowledge of what different disciplines can do will be quite valuable. And then again, as Ivy said, is so important to, sorry, Dale, just to have that appreciation that scope of practice is not static, it is fluid, and it changes over the course of a career. And so when Ivy brought up competence, from a regulatory standpoint, there's an emphasis on currency of scope, and depending on the individual profession, that's typically between 2 or 3 years. So again, Ivy bringing up the example of just because your license says you can do something doesn't mean that you should.
Thank you, Sophie. Folks, I need to move on to the next part of the presentation. I see there's some questions in the chat, so maybe Kate and Sophie can respond there. The next half of the presentation is entitled Effective Interprofessional Primary Care Teams Advancing Collaborative Practice. So now we've talked about scope of practice in the regulatory environment. What do we need to think about next? And so Arvelle Balon-Lyon is presenting with Eileen Patterson, and Arvelle is an international nurse leader and has been recognized as such as a pioneer in health innovation in Canada and internationally by the Canadian Nurses Association. And for over 20 years as a team and teamwork subject matter expert, she's led quality improvement collaboratives and engaged hundreds of primary and specialty care professionals and interprofessional teams in improving access, continuity, office flow, and integrated care processes. Eileen has led health system renewal initiatives for 20 years. She has held consultant, program leader, and executive team leadership roles in 4 provinces in Canada and across the US, including as Vice President of Quality Improvement at Health Quality Ontario. She leads improvement initiatives as they relate to the patient medical home and health neighborhoods, with a focus on mobilizing partners and teams to work together to improve all aspects of the team performance. In 2019, Arvelle and Eileen co-founded the Health Innovation Group, a social enterprise that works to foster healthcare improvement and innovation and accelerate health system transformation at the community level. So over to you as I just share my
Thank you so much, Dale.
screen.
Thank you for that introduction.
You're welcome.
So I'm Eileen, and Health Innovation Group advances interprofessional connections for better results for primary healthcare teams across Canada, bringing practical approaches that have achieved success in 8 provinces over the past 4 years. We're happy to be here to share a bit about the evidence-based models that guide this work for practice groups of every size, every payment model, urban, rural, remote, those serving very specific population needs. Today, we'll discuss real problems that can be solved by the right approaches to interprofessional teams. Do you have the right mix of team members based on the population that you serve? Are they supported to work together optimally as opposed to working alone together? What can teams adapt? How do they adapt to meet future demands? And how can we move forward together? So we'll start with the real problems that interprofessional teams help to solve. So across today's healthcare system, we have significant gaps related to health outcomes, patient experience, team experience, equity for all, and overall system value. There are certainly islands of success, but they aren't spreading fast enough, and too often they don't sustain. There is a way to see it differently and to do it better, and the evidence tells us that it all begins with access and continuity to team. They are the key. So no one provider can meet the comprehensive needs of the patient population. There needs to be a new shared approach. When a patient sees the same provider team, they are less likely to end up in emergency department, to be in the hospital, to have as many return visits to the practice, and to experience avoidable health challenges. However, prioritizing either one, continuity or access, is its own problem. So continuity and access are inextricably linked, and when achieved together, they improve the big dot problems that the system is trying to address. If there were a magic pill for teams to help improve healthcare results, it would be continuity and access to the team-based care that they are providing. So let's talk about the daily challenges, though, that can be experienced within the team. So effective teamwork helps solve the multiple problems within an organization and within a team. It helps prevent burnout by dividing work fairly and by creating a supportive work environment and enhanced work satisfaction, by building better understanding of work distribution so improvements can be made together effectively. It addresses communication and coordination issues that allow better use of time during the day. Let's use daily huddles as an example. Everyone can see then which patients are on the schedule that need special attention for comprehensive care, follow-up or screening, who's available that day and who is away. Many practical pieces of information can be shared to smooth out everyone's day. Effective teamwork also fosters the shared mental models, which enhance coordination because there's an understanding of the values and principles guiding the care decisions. This includes patient-preferred options, culturally appropriate, trauma-informed care, and an atmosphere of respect for each person, be they provider or patient. Finally, it ensures clear task assignment, which reduces duplication as well as gaps in care. So silos, conflicts, and power struggles are real problems that are best addressed using an intentional team-based approach. This happens by supporting team planning and teamwork. Our healthcare system as a whole needs teamwork to help solve these two critical problems as well. Patient safety and fragmented care. Healthcare professionals can share critical information about patients, ensuring that no important detail are overlooked and that care is coordinated across different providers and settings. Effective teams develop the standardized protocols and procedures that promote consistent and reliable care, reducing the chances of patients falling through the cracks or experiencing gaps in their treatment, other gaps. So staff retention and worker shortage is another priority, and these have never been as profound as they are today. We need to support each individual team member to optimize their satisfaction and contributions. By fostering a culture of teamwork, trust, and mutual respect, organizations can increase the likelihood of staff members staying, and cross-training enables them to develop skills in multiple areas. This flexibility in the roles and responsibilities helps to mitigate the impact of worker shortages and ensures continuity of service. Arvelle, I'll pass it over to you about how to design the team.
Thank you, Eileen. So in primary healthcare, designing the team focused on the needs of the panel population is really a foundational principle for successful interdisciplinary teamwork. So let's move on to the next slide and explore this a bit more. So today, the stage was set really nicely about how important it is for highly effective teams to have an awareness and appreciation of each other's responsibilities and how these fit together to meet the needs of the panel population. So forming the team and defining roles and responsibilities around the panel population needs to be top of mind. And it's not always been the way that leaders and teams have gone about their work, and really may have contributed to team silos and some of the power dynamics we experience today. So there is a set of evidence-based principles that have emerged to divide and advance teamwork for comprehensive patient care delivery, and is resulting in really positive teamwork behaviors within primary healthcare settings. Starting with defining, as I've mentioned, the needs of the panel population. So this would include usual things like panel demographics, age, sex, complexity, but also thinking further to include patient preferred approaches to care and social, cultural, and other determinants of the population, to name a few. So in primary healthcare, there's a significant need for generalist expertise. We heard that and saw that in the comments, balanced with specialist expertise, especially in primary care practices. And this is an important consideration when determining who could or who should support the work to meet the needs of the population. A helpful way to consider this generalist approach is defining roles and responsibilities, looking at the just-in-time work. We also heard that in a comment today. What could the patient receive today versus what could be tackled a bit later? This is important when we're balancing continuity and access. So this means that those multidisciplines providing today's comprehensive care might need information or access to tools and resources that might usually be supported by a more specialist team member, and that may or may not be present, that team member within the practice. So a great example would be responding to the needs of a pediatric patient with asthma. It would be beneficial for the generalist team to have access to reducing environmental triggers, early treatment recommendations, even spirometry, while later consulting with the respiratory team for personalized approaches and additional treatment recommendations. This leads into purposeful discussions about cross-training opportunities and what resources are available to the generalist team and in that community. We heard today about scopes of practice. So of course, it's important to consider the highest scope of work for all professionals as per scopes of practice, but also considering the role to supplement care, like medical office assistants and outreach supports that are critical to the primary care workforce. So in summary, the principles begin with examining the needs of the panel, discussing what expertise can be shared, generalist work, and what expertise is specialist work, including cross-training and considerations and adding to the team and supplementing care. The next picture, as Eileen described, go ahead, Dale, really is a helpful tool that helps care teams. So the care team, the worker, what you see here on the right, has the responsibility to care for the entire patient panel needs, which is described here on the left, which is expressed in care demands, often in appointment requests. Therefore, they need to understand the distribution of the panel across age, chronic disease load, other preventative needs, other comprehensive needs, and unmet care needs. And too often we guess and we plan our service delivery based on hunches, or we base it on current care team parameters, who's available. So ideally, the team shares in the responsibility of caring for these patients, and this requires coordination and careful choreography to meet the needs of the panel. The more you know, the more you know about the patient population, the better you can plan for it. And one thing that I wanted to highlight, that it's important to recognize that the panel generates both appointment work and non-appointment work, so which can be actually shared in both in-person or virtual care options. And today we have other options supporting asynchronous care, including secure messaging and more. The next slide shows a helpful tool that starts by identifying who does or who could do each of the functions. So often determined by scope of practice. Based on the principles, they decide who will do the function based on the needs of the panel and team composition. So in this case, you'll see this is an example where the green mark, in this case, it is shown in a green check mark about who could. And the yellow check marks show which tasks a provider might stop doing so they can focus on other priority responsibilities. So this tool is helpful to start conversations that'll optimize the team's overall clarity and roles and responsibility based on those population needs. I want to describe some customized support for primary healthcare teams to advance interprofessional practice. So Health Innovation Group takes interprofessional teams through a series of modules, the science and foundations for highly effective teams, looking at the 7 C's of teamwork, which I'll describe just a bit more, designing teams for impact, which includes the principles to determine roles and responsibilities, who could, who should, enhancing your team effectiveness, establishing those shared mental models, psychological safety, and the top 10 things that the high-performing primary healthcare teams do. And then really critical to the conversation is providing that team-based, person-centered, and culturally appropriate trauma-informed care. And then diving into quality improvement team tools for team capacity building. So each module includes a call to action with practical tools and resources so teams can measurably enhance their performance. Here's a little more about the 7 drivers of teamwork, or the 7 C's, to get teams practically thinking about their strengths and opportunities for improvement. These were developed by Dr. Eduardo Salas. Many of you may know about his work, the most published team scientist in the world. He works with leading organizations such as NASA and Vermont Oxford Network, and we've had the pleasure of working with him within Health Innovation Group. The 7 C's look like this: capability. Do we have the right people with the right mix of knowledge, skills, and attitudes? Cooperation. Do we have the right attitudes and willingness to team? Coordination. How best do we demonstrate teamwork behaviors? Communication, using those practical approaches to communicate effective internally and externally through our handoff processes. Cognition. Do we possess a shared understanding of the work? What's the priorities? What's our role together to meet them, and the vision of the team and clinic? Coaching. Do our clinic leaders demonstrate leadership behaviors? And most importantly, conditions. Do we have the favorable conditions for teams that are determined by leadership and organizational priority setting? The next slide shows a set of team tools that are focused on improving each one of the drivers of teamwork. So each tool is uniquely valuable and practical and has a specific purpose to help teams move forward based on their context. So I'll show you a few examples. So thank you. It's great to have a model and some tools, but how do you actually make these changes? And we heard that in the interest again through the conversation today. Well, there is a practical approach, and that often high-performing teams use, and that is to form a teamwork quality improvement team. So these practices have a routine for planning improvements, including improvements in how they coordinate their work, how they wrap services around each patient panel. This tool shows here on the right the sequence to achieve change, a 7-step process to plan, test, and implement improvements as a team. So team optimization doesn't happen by just co-locating or just having team conferences. It really does require a planned, systematic approach. And this one has been well proven that using these QI tools and applying it to the teamwork context is very significant and helpful. As I mentioned, here are a couple examples of team tools. On the top left is a tool to build shared mental models, or from the 7C perspective, that shared cognition. It guides teams to clarify the goals and the reasons they're working together on them. On the bottom left is a patient's medical home self-assessment tool. This tool has been adapted over time and shows the distribution of individual ratings provided by each of the team members, often a baseline to help the teams develop a consensus score of where there are priority areas to work on. Each of them each section in the PMH self-assessment tool addresses one of the high impact changes for primary healthcare teams to optimize their practice. One of my most favorite is on the right is the team huddle checklist. Teams of all models and payment and design actually tell us this is a difference maker. For most of them, they gather together either virtually or in person to huddle around those shared priority patients within the panel. So how might it be different? We've talked about some tools and approaches, but there is aspiring work to still strive for. So teams across Canada are finding ways to work together for better experience for patients, focus on access and continuity. But instead of siloed care, here's just an example that we pulled from work from a published white paper that was released in Alberta, which explores preferred pathways to care. So I won't go into detail, but critically important is that patient preferred pathway or perspective based on their social circumstances and needs, which determines care delivery mode preferences and often tailored team approaches, which are really applicable to primary care practices today. I want to highlight a couple of real examples here. It's helpful to work with teams to create visuals to see and understand their current ways of doing work and plan and prioritize improvements in roles and responsibilities together. This process map on the top left shows the typical steps that occur for a patient through this particular practice, but often they'll map as they're handing off to other care team providers. The top right's a pie chart showing providers how much of their time is actually spent doing direct patient care versus non-direct patient care or providing care for others not on the panel. This is really an important aspect of balancing supply and demand for the work. The bottom actually shows access to care as measured by third next available. So teams can plan and work together using quality improvement tools, and they have this type of visual information and measures to inform decision-making. Eileen, I'm going to hand it back to you.
Thank you, Arvelle. So primary healthcare providers are continuously learning and adapting. And so what are the right next steps for your group? Well, team improvement concepts apply to all sizes of teams. So let's look at your situation. Do you need more team members? And if so, which discipline? Or would it be better to focus on supporting and connecting the team members that you already have? Maybe you have a small team and can't officially hire more disciplines. Then consider finding partners for better coordination and transition. So, for example, sometimes in rural communities, then practices can partner with rural hospitals and share the resources of respiratory therapists or dietitians who might come and connect with the primary care team part-time to support their common group of patients, or work on better flow of communication with community pharmacy, for example. Whatever size team you have, together you can review patient population needs, wait times, issues, and focus on continuous quality improvement together. Access to a practice facilitator to support these changes really matters. It will help with uptake of new ways of working together. Health Innovation Group works with teams to be organized to support the needs of their patients. They are guided to embed proven teamwork behaviors for evidence-based comprehensive care. There are 9 high-impact changes that together are the best path to being a high-performing team for patients. And they all depend on teams and teamwork as highlighted here. But not enough team members have been provided with the practical tools for quality improvement, panel access and continuity, clinic flow, panel management, and person-centered interactions together with coordinated care and seamless transitions. That's why we offer a national program that organizes all of the evidence and practical tools in one place. So the National PMH Expedition Program brings all of this for teams of all shapes and sizes as a group of practices meet together to make the changes. Teams don't have time to go through and research independently and make all the adaptations for the set of high impact changes that can help them reach their goals. So this program has organized it and is led by those who've been through it and have proven success guiding others to be successful. It starts this fall, and because teams are testing and making changes as they are learning, it is a one-year journey. There are also other focus programs that do a deeper dive in one particular area of the high impact changes. So Teams and Teamwork is one such program, some of which Arvelle introduced today and is being launched in November as well. We also have 2 more focus programs that we just wanted to make you aware of. The first promotes more efficient clinic flow and helps you get the whole team home on time. The second focuses on planning comprehensive care for your patient population in an integrated and coordinated way. These are guided team learning events with your peer groups led by experts and providing you with practical tools and approaches that will save you time in advancing your goals and reaching your priorities. You can get registration information or more information about any of these programs at healthinnovationgroup.ca. So to promote effective uptake of behavior changes, though the evidence is clear, teams, and I'll emphasize very busy teams, are 3 times more successful with practice facilitation group. So Health Innovation has national facilitation program supports for all as well that are appropriate for clinicians and non-clinicians. So I want to thank you for being part of this important discussion around advancing teams for the patients that we serve across Canada. Thank you.
Thank you very much. I just wanted to open it up to questions, and I also see there's been some questions and discussion in the chat. Anybody have some specific questions around once at the coal face? What do people do? How do we roll up our sleeves and improve teamwork when push comes to shove? Perhaps Eileen or Arvelle, you could give us a sort of a concrete example of a team that you've worked with that perhaps the roles were not as relative roles were not as clear as they could have been, and some of those difficult conversations or challenges that you've met, and how you addressed them or how the team addressed them, and some of the adaptations that were made to move forward.
Certainly.
Great, Eileen, please do lead us off.
You bet. And so we have examples from very small teams where they said, you know, we're really just 2 or 3 people here. And they moved from being friendly collaborators to actually understanding how they could help each other and move to team. And so there are great examples of that across the provinces. But in particular, I'm thinking of Newfoundland, who has actually really been investing in the last 4 years in supporting primary healthcare differently and building leaders who understand these concepts to deliver peer support. And so process mapping and the huddles together would, I mean, they're not, they have been ones that people have shared with us to say, this is how we use these and adapted them and use them to look at our work differently. And from a larger perspective, we also are working in several provinces with organizations that are highly teamed, that have, you know, that have 8, 9, maybe 10 different disciplines and multiple representatives of each. And where they found that, though, through historical work or just the way that they emerged, were had sort of subdivided into separate little mini teamlets. And so found that by using something like an integrated care plan, they could come together and look at the whole needs of the patient and think about the whole needs of the patient, and then use some of these tools around who could and who should and may, and how do we make sure that we are aware of how to leverage each other's work. And so in their case, integrated care planning was a critical tool, as well as the mapping from the patient provider perspective. And I was hearing the stories, and the example of Well Baby, for example, came up. And I worked with a team where we looked at all of the needs of Well Baby for the first 2 years. And primary providers and public health providers came together, public health nurses, and said, well, we're both doing this and we're having an issue with that. And so they reassigned how they were going to work together, share information together, and reinforce common messages for just a greatly improved experience for young families.
Great, thank you. Arvelle, do you have any other examples that you'd like to share?
Yeah, I certainly have favorite examples that are on both ends of the spectrum, but one in particular, you know, working with teams who say, well, we don't actually have a team. It's just me and my receptionist and or medical office assistant. And from time to time, we have other supports that visit us, but actually helping them move to say that is the team, and starting to say, you know, let's look at the needs of the patient population that you serve. What is the work? How can you share in the work? And really fostering new teamwork behaviors. So these small team discussions, along with the larger ones that Eileen has highlighted, are really transformative in first identifying what's the work and how do we share it? What are the needs and how do we come together? And often scopes is not the first discussion they have. It is really around that panel population needs, and then looking at, well, how do my training and my expertise support the ability here to move patient care forward. So thanks for those questions.
Thank you. And we're right on 1 o'clock, so perfect timing. Thank you so much to Sophie, Kate, Arvelle, and Eileen. Much appreciated. I think that there's a lot of food for thought. These webinars are recorded. They are jam-packed with information. So I don't know about you, but I probably need to go back and watch this one again. So again, thank you very much for joining us. Our next webinar is in August. I'm sorry, I don't have the date right at the tip of our fingers, but we have a presentation from the NHS as it relates to change management. So negotiating continually how to work with change management approaches within your primary care team. The other thing, just so that I don't forget, when you log off, a survey is going to pop up. So please complete the survey as you leave us. So see you again in August, and have a great summer.